Hey. All right, no deviations away from the mic, man. Hey.
Walking, 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 walking. I'm just walking, walking, walking.
Walking.
I'm just walking, 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 walking.
Can you present yourself?
Yes, I'm Sarah, and I used to see the medical algorithm part from ClickDiagnostics.
Hi, I'm Bayat. I basically look after the Bangladesh operations and lead the projects that we're doing here.
I'm Imran Chaudhary. I'm working on the Click team and focusing on the research and development part.
Hello, I'm Maya. I'm working as a program manager at ClickDiagnostics.
I'm Dr. Bashar. I'm leading the medical intelligence department of Click.
I'm Ridul Chaudhary, the CEO and one of the founders of ClickDiagnostics. And we founded ClickDiagnostics when we were students, graduate students of Harvard and MIT. And we basically, the concept of ClickDiagnostics started in a class. It's essentially about strengthening health systems, because there has been this trend of using information systems or databases to make reporting structures more efficient within health organizations. But we came in with a different angle. Our angle essentially was that information systems have to be used for direct healthcare service delivery strengthening. So we are basically using information systems for various kinds of strengthening of health organizations.
So in BRAC we have these health workers who go to various households and provide care to pregnant women and children. So they normally used a pen and paper based system where they filled out some data regarding the patient in order for monitoring and reporting purposes. So we essentially provided these health workers with a mobile phone. And this mobile phone basically had a series of questions in a medical algorithm, so step-by-step questions with multiple choice answers, which the health worker could fill in their native language. So they could use it in Bangla, type in the answers, and then send it off to a server, right? So these are the algorithms that we made. It's just a visual representation of it. So after they put in all the data and sent it off to a server, you could view it on basically some kind of a web page. Right?
On the web application.
So you could log in and you can basically view all the information that is coming in from the ground in real time. So let's say in 5 seconds ago you found that there is a data that came in 5 seconds ago from a health worker. And this could be from anywhere. So from anywhere in Bangladesh they could basically send in the data and you could view it in real time. And the system basically analyzes this patient data and comes up with a risk categorization. So for pregnant women, you have various risk categories: low risk, medium risk, and high risk. So we basically categorize them through the system into various risk categories. So, and then a doctor could basically sit down on this interface and choose to view only the high risk patients. So the high risk, you can also, I'm sorry it's a bit small, but you could see the risk level here, 1, 3, 3, 0, and so on. So the doctor could basically decide whether they want to view the high-risk patients first. Okay. And they could basically go in here, click on view, and that would bring up the patient's data, right? So they could view all the data that has been collected about the patient with a picture and with the name, and then there is a box where the doctor can basically write down some advice for that particular patient based on the data. And as soon as they type in that advice in the native language again, so they need to communicate it back to the health worker, so they need to write it in Bangla. So they can basically write it in Bangla here and submit it, and that instantly goes back to the health worker's cell phone. And the health worker can basically convey that message to the patient. And also the doctor can basically set the work schedules of the health worker so that if a high-risk patient comes up, you can basically follow them up more frequently than other patients.
So basically, I mean, the pregnant women, I mean, they feel that they're not really connected with the doctors, because when the community health workers come, and the community health workers, they know are members of their community and they're not doctors. So what our system enables is basically, it allows the community health workers to sort of serve as conduits for remote doctors. So we are basically changing the whole perception of these community health workers from being sort of medical advisors themselves to messengers of remote doctors. So it's a complete change in perception. It's also somewhat empowerment for them, because they feel that they're sort of the eyes and ears of remote doctors on the ground. So it's empowering for the community health workers because they feel they're always backed up by doctors, and it's also comforting for the patients because they feel that their advice is essentially coming from remote doctors and not from the community health worker who they know is not medically trained. Okay. So that's how it's empowering and also comforting for patients. One of the main challenges is whenever we talk about use of information systems for direct service delivery, we're basically talking about holistic change within organizations. We're talking about change of project objectives as they were originally designed. So there's a lot of change management that needs to happen before information systems can be actually used effectively enough. So one of the biggest changes is basically that, how do you get people motivated enough to use information systems effectively?